By way of introduction, I'll talk about myself and my training. We'll talk about some personal motivations, and then we'll talk about your motivations, and then we'll jump into, really how do we do contouring for cervical cancer that's intact? And by way of background for me, I'm from the United States. I'm a native Tennessean, so you can see a map there. I grew up in Nashville, Tennessee, but I trained for about a decade medical school and residency and research in Memphis, Tennessee, which is the University of Tennessee was my residency, and my city's famous for barbecue and Elvis Presley, and his home there is Graceland. It's also famous for St. Jude Children's Research Hospital, where I was able to spend quite some time in training and research. And I also was able to go to Boston. I attended Harvard and did a master's in public health because I am very passionate about care at scale. And then as I ended my training and was starting to look for opportunities, I began working in my hometown with my practice, Tennessee Oncology. And Nashville is a few hours away from Memphis. It is the home of country music, and it is definitely a center for healthcare in the United States. And I work at a large hospital's really main hospital called Centennial Medical Center there on the right. And so, there are days where obviously we all have challenges, but as a whole, it is a comprehensive cancer center that's, providing academic level care. We're doing a lot of clinical trials. We're doing a lot of sort of cutting edge treatments in that center. And I pinch myself that I get to operate in that environment. But I certainly understand we're from all different backgrounds. So I want to show you, the basics of what we're doing so that we can move towards advancing wherever you're at, the standard of care for your patients. So, Michael, I think you have the wrong slides, or actually I have the wrong slides. So let me pull up my correct slides here. Just one second. Now remember who's sharing their screen. I'm so sorry for the delay, folks. Okay, this should be the right one. It's not a Zoom call without some technical issue. That's what I've learned from Zoom calls. Okay, we're on the right deck now. Okay, so I want to share with you just a background of what my personal motivation is as a clinician and human being, because I genuinely think that I can teach you the technical information today, and you can look that up for the rest of your career. And I'm going to show you the resources for how you can train yourself. But for me, the thing that I couldn't look up and I couldn't learn was how to practice the art of medicine. And my mission statement is very clear. I am here to elevate the standard. And what that means to me is wherever I find the ball on the field, I want to pick it up and advance it and contribute to my team's success as far as I can run that ball, as far as I can move that ball down the field. And I'm a participant or a contributor on a lot of different teams. So if I entered my practice years ago and I asked myself, how do I elevate the standard? It's every day showing up and letting your presence, your way, your character, your leaderships move into your setting and contribute, not control, but contribute to the advancement of patient care in whatever it is you were touching that day. And so some of us, I'm a generalist. I can see everything in terms of the adult sphere in general. What I find is that I treat a neurosurgical brain case. I want to elevate the standard as high as possible for that brain case. I'm next going to treat a breast case. I want to elevate the standard, whatever that looks like, for that breast case. The next case is a GYN case. Okay, I want to elevate the standard for that GYN case. And the mindset, that growth mindset of elevating the standard is my mission. And so I would just want to clearly say there's two groups of people here. One, a group of physicians. Two, a group of physicists. The good joke is a doctor can heal a patient at a time, and a good physicist can heal 1,000 at a time, and the converse is true. A bad doctor can kill a patient at a time, and a bad physicist can kill 1,000 patients at a time. That's a little bit dramatic, but I think it gets to the point of we work in teams, and our impacts have ripple effects. And so another saying that I like is some doctors are called to treat a patient at a time. And other doctors or clinicians are called to elevate the standard of care for entire communities or regions, populations at a time. And I would ask you to see yourself as the latter. If you're in this course, you've got a growth mindset, you're a leader, view yourself as pulling up the standard of care and elevate the standard across your career in whatever setting you're in with that lens, because that's the truth. As a radiation oncologist, you bridge every cancer service line and you get to raise the standard of care of an entire population every day you show up at work. It may not feel like that all the time, but that's certainly what can happen through your good work. So that's the mission. So the second thing I want to share with you is what has kept me going. And what I've learned is my passion is putting on my heart what is on my patient's heart and tuning into their goals. And so what I want to do right now, before I get into the technical component of this lecture, is share with you what I wish someone had shared with me clearly. And it's essentially a script. And what it does is sets the stage for a therapeutic relationship with your patient. It's very scripted, but it also comes across as very organic, and it reflects me, and it reflects an honest and authentic description of who I am and what I care about. So take it or leave it. You may not have the same script. Adapt it to your setting and your values, but know that having a script to establish a therapeutic relationship with your patient is like a superpower. So here's the script. It starts with a joke. It pivots to a spiel. The spiel is a question, a, a guiding answer that builds trust with the patients, and then the question again, and then listening. And then I move into the business of the consult. Okay, so this is how I enter a consult. I come in the door. My nurse has already seen the patient. I make a joke. I introduce myself to the patient, their family member. I say, I'm Dan I'm Dan Wakefield. They tell me their name. The family tells me their name. I say, you've already met my boss. And I turn with a smile and gesture towards my nurse. And I say, and I joke. I say, I have one boss at home. Well, really two. My wife and my 3.5-year-old son. And here at work, I have 40 bosses. But Caitlin, my nurse, she's the commander in chief. And I honor her. I say she keeps our world running and she is so good. So in that moment, I set the standard of an honor culture and glorify my team. Then I pivot. I say, we're going to talk to you today about what and how. And I know Caitlin or the nurses have already talked to you a little bit. But before we get into that, I want us to get to know each other a little bit better and get into your why. And they pause and I say, I have a spiel. Can I give you my spiel or my introduction? And they always say yes. And I say, well, my spiel is a question. And so I'm going to ask you a question. I'm going to give you what I would answer it just to guide our conversation so you can understand what we're going for. And then I'll ask the question again. And far more importantly, we will listen and talk about your answer. Pause. So here's my spiel. The question I have for you is, what matters to you? For me, as an example, if I were to answer that on a personal level, I would say my faith, my family, the future. On a professional level, I think about three things. The product of our work as a team, again, glorifying the team, the product of our work as a team is creating three gifts for our patients, the way that I like to think about what we do. And then 1, 2, and 3. The first one is the gift of truth. Doctor in Latin means teacher, and I like to get back to that when I meet my patients for the first time. So my goal today is to answer your questions. And whether I treat you or not, I want to answer all the questions that I can. And my bad joke is they may pull me out of here, but I will keep coming back to your questions are gone. So whether this is 2 minutes or 2 hours, there's no rush. The second thing I say is the second gift is the gift of time. We get to be in the business of birthdays. And our gift to the world is more grandmas and grandpas. And so more birthdays, more holidays, whatever good the good Lord has called you to, I want to see that good continue on in this world. And if that's not your goal, please let me know. The third gift we give our patients is the gift of true peace, the gift of peace. And that's a little more vague, but what that means to me is a sense of peace of mind or confidence when your head hits a pillow in a year or 5 years or 20 years, that in this season of your journey, you understood the problem at hand or the puzzle that we had to solve and the options that you have for solving it. And only you can go through this journey. So whether a cancer goes away and you have no side effects, which is entirely possible, if not probable, or you have a cancer come back despite cutting edge treatment, or you have a side effect that bothers you, even though you're cured, I want you to have peace of mind when your head hits your pillow at night. And this might be selfish, but I want to have peace of mind when my head hits my pillow tonight that every patient across this hallway got a treatment that I would give to my own body or I would give to my own family, sort of a do unto others. And if it doesn't meet that standard, I push the red button, I stop everything, and I make a call to my patients and we make a change and a decision together. So that's what matters to me: truth, time, and peace. But none of that is as important as what matters to you. And I pause and I take a breath and I listen until they stop talking. Most of the time. And it can be 2 seconds, it can be 20 minutes, but I listen. And in that moment, I am tuning my heart and my craft and my skill to what they need and help them meet their goals. And that patient-centered moment is what has kept me passionate about my care. And it has afforded me this opportunity to have a therapeutic relationship with my patients. I've heard lots of answers, right? I love these answers. The answer, recently I got was sex, drugs, and rock and roll, man. And I'm in Music City. I work with a lot of artists. I had an artist say, I want to keep the joy going. I love filling stadiums with a, you know, room full of joy and creating that experience for people. And most people say, honestly, most people say, in my practice at least, they say some version of, yeah, I agree with your faith background. That's really important to me. Or almost everybody says my family. And those are moments where we establish some sort of rapport and connection. And so I'm teaching this. You may not have a wife or a family. You may not have, the same backgrounds that I have. You may not have even the same energy or interest in participating with people. But what I can tell you is that moment of establishing a therapeutic relationship, a trust-based relationship, allows me to make more effective care for my patients. When you look at randomized clinical control trials of blood pressure, the placebo effect is 30% across trials. This is incredible. It's crazy. It's psychology. If you give someone a sugar pill versus a real blood pressure medicine in a randomized control trial, 30% of the time, it makes their blood pressure better. Okay? And hopefully we hope the blood pressure medicine actually works much better than that. But if you can create trust with your patients and when they look at you, they know that this has a chance of working and that they trust their doctor, I think that all the little skills that I'm teaching you how to learn now will be much more effective. And so that's why I start with that. And I saw a question, what if you don't have a wife or children? I think that's just a joke. That's just an entree to my spiel or the introduction. But I think it's really important for you to establish a therapeutic relationship with your patients. And I want to start with that. So let's move into the
Yeah, and I
lecture
just
here.
wanted to thanks so much for the intro. Just one, it seems like some of the closed captions are being put in Arabic for some reason. So if you can look at your Zoom settings in the closed caption area, there's a little arrow, and make sure your speaking language is English. I think it may have just got like the setting switched for some reason, but
Oh, that's strange. Okay. Well, let me stop share just a second and see if I can fix that.
yeah, sorry about that.
No, that's okay. Thanks for telling me. Okay. So I look at the bottom, right?
Bottom right, there's a closed caption area. If you click that arrow up and then go to my speaking language, it's in captions and translation. And it might be set to Arabic because mine looked like it got switched to Arabic at some point for some reason. So I think yours may have as well. And so it's showing up as Arabic for, I'm sure it's nonsense, but yeah.
Yeah.
Are you seeing that area?
Yep,
Microwave?
I'm finding it. Give me just a second. Or captions. Oh my gosh. My goodness. English. Do you want English or French?
English. It's your speaking
Okay.
language. So yeah, English is perfect.
Okay. So does that look better?
Yes, perfect. Thanks
Okay.
so much.
All right. Here we go. Okay, back into it. Okay, so the bulk of this lecture is actually teaching you how to find resources so that you can go back to this and confidently run essentially a checklist. Okay, so the first thing, let's see, I have gallery view here. The first thing, goodness, move this to the side here, X this out. Okay, so, oh man, I feel like this was the wrong week to get a new computer installed. Okay, so the first thing is how important you guys rank this. Overall, this was above 8.5 out of 10 importance to everybody. So we've got radiation oncologists, radiation oncology residents, medical physicists, and radiation therapists. And many of you are in different settings, but all of you say that learning how to contour is very important and you want to practice. That's the practice is the thing. So today is a lead up to show you the resources that you can go back to, and I still go back to, that are the gold standard so that you can move into practice and practice improvement. And so,
Your screen right now, if you can just probably reshare.
can you see it now?
Yes, perfect.
Okay. So some polling questions here. How many cervix patients would you estimate did your cancer center or your center or clinic treat last month? And I'm going to give you about 30 seconds to answer these just to kind of poll. Man, some really high volume centers, 10%, yeah, that's you guys have some really large centers. I wish we had made this more granular, but I'd like to know if, the spread of the 0 to 50. But that's great. Okay, let's go to the next poll. The next question is, do you have on-site brachytherapy at your center? Yes or no? Okay, that gives me a good poll there. I feel like I have a pulse. So 3/4, and thanks for the engagement here. 100 of you responding means, you're focusing on the talk here. And then let's go 1 to 10. What would you rank your confidence in contouring for cervix cancer patients, at least right now? How confident are you? All right, we're all over the board here. So this is great. That's great. So I want to take everybody's confidence up, and hopefully at the end, when we do this again, we can see where you're at in terms of confidence. So, all right, Michael, I'm going to X that out. So the general philosophy here is give a man a fish and he will eat for a day. Teach a man to fish and he will eat for a lifetime. The twist on this is teach someone to love fishing and they'll go fishing for fun the rest of their life because they love doing it. And I think curing cancer is a lot of fun. And so not just how to do it, but to do it because it's enjoyable is important too. So I'm going to show you the gold standard resources that we're working from. Okay. And these are all very accessible. I'm going to minimize this. Okay. So there are some websites out there that have a summation of incredible resources that are all updated. Okay. So there is a website called Radiation Oncology Virtual Education Rotation, or ROVR, and it has live links to everything that I'm talking about here. Okay? So the gold standard is, in our country at least, the NCCN guidelines. You can get a free login, and it will tell you, it's like a textbook on every single site, how to take care of cancer patients with any type of cancer. You can click on that type of cancer. You can go to international professionals and you can find not just an algorithm of how to take care of patients, but how to take care of patients for each individual situation. So let's say you've got a question about radiation therapy, the little tab there about principles of radiation therapy will take you to the section in the handbook about how to do this. And you can read through, obviously it's in English, but you can read through how to take care of patients, at least in America, with what they consider should be the standard of care in our setting. Okay? It has all of the different opportunities. I'm not going to belabor the details here. I'm showing you a resource. And then at the end of this is a textbook that is updated quarterly with the most recent research from the entire world on how to take care of patients. Okay? So that's the gold standard resource I would hold up that really everything else probably could be considered to flow from. Okay? There's another free resource that takes this website and has reduced it down to a more accessible version. It is called RAD-ONC tables. And there are links here. Click on this one. It'll take you to the summary of the NCCN. And then it will take you to a list of key studies that will show you what the data says and why those guidelines have been created based on that data. Okay? So let's take, for example, GYN, which is our topic today. And this is essentially what's in the NCCN in a table format that you can search, Control F, CTV. Oh, I can't remember what the CTV should be, or HDR. I can't remember how to do HDR for this. You can search this really quickly and really easily and get answers for yourself. And so when we talk about 3D based treatments, these general treatments apply. All of the things that I'm going to teach you today talk about how to set up your fields, okay? And you can go back to this every day the rest of your career, just like I do every day in my practice, and look it up if you can't remember, okay? It has a deep well of resources. If you have questions about outcomes based on your practice and what you would be expected to, predict would happen from the data that we have, there is an entire, very, very good summary of the data right here. Okay, and this is the key studies tab. So some of you may know about this resource, others of you don't. It is my method of practice. There is another resource that we're going to get into today called eContour. And you click on this link, it'll take you here. There is a free login that shows you how to contour all these different types of cancer cases. And today we're focused on intact cervix, excuse me. And we are using this case as an example for my lecture today. So this case, I'm going to be hopping back and forth from, just to orient you to eContour. It's a free resource. It has all of the organs at risk, and it has how to draw the bladder, the rectum, the sigmoid according to the national guidelines here in America. And I literally use this every day that I practice. It is so helpful. So we're going to get into this. It will also teach you how to contour the targets that you want to treat. And we're going to get into this in just a second. Okay. So in the spirit of review, I want to show you, if you have a web-based access, all of you are on their net right now, so all of you can get this right now, even on your cell phone. These are incredible resources that we're going to go through today. If you don't have internet access, and sometimes you don't, there is an excellent book that I would steer you towards called The Handbook of Treatment Planning. It has a lot of radiation oncology three-dimensional fields in it, and I think that's a very good book. And I keep it on my desk as well when I have a question. So everything from whole brain fields, which is all kind of 2D, to pelvic fields, which we'll talk about today, which is really about the same as 2D. And a lot of the contouring information is in there too. So as we move into this topic, I want to just say cervical cancer is challenging to manage. We have the goal, based on analysis, of getting whole pelvic radiation with concurrent chemotherapy, followed by definitive brachytherapy, all done in 56 days or less. And that is actually very challenging to pull off in resource-heavy settings. It's also going to be more challenging to pull off in limited resource settings. But when you get it right and you cure a patient who came in bleeding to death, all the way to being cured and continuing to be the mother or the grandmother of their family or their tribe, you have to know that you have done the life-saving thing. And that is extremely rewarding work. So there's ripples effects. You may affect 1,000 people by saving that one person, and it's incredible. But it is a professional and technical symphony that requires multiple treatments with the correct timing all along the way. It's beyond the scope of this lecture to talk to you about HDR, but I am talking to you about how to contour in this within this setting. So many of you are moving from the two-dimensional or are already in the two-dimensional to three-dimensional era. And eventually, if not already, some of you are going to move into the IMRT era. But I will say this, honestly, the 2D and the 3D technique is pretty much the same. It does not require any contours to deliver a four-field box to the pelvis. And we'll talk about that at the end. But really what contouring is a bridge towards improving your skill, towards the new technique, hopefully that you could one day have or already have and want to get better at, called IMRT. And it can take years to learn how to do it well. So this is a resource for you to prepare so that you can learn to contour if your center is in the bridge between any of these techniques. So let's move into how to do it. And what I would propose to you that you could do is copy and paste this slide, you'll get the slides later, and create a checklist for your center of how to simulate for a cervical cancer patient. So let's just walk through it and I will detail what it says. You will simulate on a flat surface with a CT scan. 3 mm slices are used to cover the entire pelvis. I usually scan from about the bottom of the diaphragm to the middle of the femurs. The patient is in the supine position. If you are doing IMRT, having a VACLOC body mold or body bag, like a bean bag that will fix the patient in position, will keep the rotation of the body, trunk, proximal legs from happening. I don't know that that's necessary for 3D, but it helps with IMRT. Things to consider. At my center, we use vaginal swabs that are dipped in contrast so we can see the length of the vagina. We use an anal marker or a BB bead placed at the anus. If there is suspicion of bulky lymph nodes, we will use IV contrast. Or if there's local invasion, we will use IV contrast. Sometimes we will use oral contrast to show the small bowel. Patients drink that about 30 minutes before the scan. It's a barium smoothie. And if there's rectal invasion, some centers, we don't really use this at our center, we will use rectal contrast. Okay? The next level would be, not taught in this, would be considering an internal target volume by having a full bladder scan and then having, with all of this set up, and then having the patient get off the table and go to urinate and pee, and then bringing the patient back and doing a empty bladder scan. And that, if you're moving towards IMRT, I would suggest would be the highest standard of care. When we do the full bladder scan, what that full bladder does is it pushes the small bowel up and away. It's done that way during treatment. You want the patient to have a full bladder during treatment. And what that does is it allows you to have less bowel dose because the bladder will reduce the bowel dose. So if you're using IMRT, you want a full bladder scan and an empty bladder scan. We use markings at my center. Historically, we used to use tattoos. and those will align the patient when they return for treatment. And every day during treatment, at a minimum, we do daily portal images to make sure that the bones are aligned. And at my center, we have cone beam CT scan availability, and we will do a full bladder cone beam CT scan daily to make sure that the targets are all accurate. We're doing IMRT for our cases. So again, if you want to look at how to do this, you can go to eContour in the case that I showed you. And as we move through this, I'm going to bounce back and forth from this slide back to that case, and then we'll finish up.
Hey
So
Dan,
first
we
and
got a
foremost,
question in the chat that someone was hoping you could clarify a little more detail about why you do the simulation with both full and empty bladder for intact cervical cancer.
yes. So if you are doing a 3D technique or an IMRT technique, and you can look in the future, or if you're moving towards the highest standard eventually, and you're able to do this, knowing the motion of the uterus and the motion of the cervix and the cancer in the cervix every day can help you have the most accurate target. And so what the full bladder scan does is shows you where the uterus and the cervix is when the bladder is full. And then when the bladder gets smaller, you will see the whole pelvic anatomy change, and it can move. Some of the studies will suggest it can move up to 2 to 3 centimeters back and forth, just depending on the patient. And so if you do one scan, I'm going to show you the method, which is with a full bladder scan. If you do one scan, this method that I'm going to show you will accommodate for that motion by wider margins. But if you do 2 scans, you can potentially have an idea if you're moving into the IMRT era, and some of you have that bridge right now or are already doing it. It will allow you to have smaller targets, so hopefully you have less toxicity. Okay, so let's move into, I think that'll make sense whenever you see the contouring. Okay, so there are different targets. Okay, so we're going to talk about the GTV, which is the gross tumor volume, which is the tumor that you can see on the CT scan. The CTV, or the microscopic tumor target volume, is the GTV plus the cervix plus the entire uterus for CTV1. I'm going to show you that here. So I'm going to turn all of these off. And as you can see, what is contoured here is the top of the uterus all the way down, all the way down, the entire cervico-uterine junction, the entire cervix, and then the top of the vagina here. Okay, so that is CTV1. All right. Okay, so that's CTV1. CTV2 is the parametria and the superior vagina 2 centimeters below the most inferior extent of any given tumor. And this is what that CTV looks like. The parametria right here, where the vessels and ligaments come in, and then comparing that to CTV1 here, you can see that caps the top of the vagina, top 2 centimeters right there. Okay? And then you build and draw CTV3, which is the pelvic lymph nodes. So the pelvic lymph nodes look like this. Okay, so the yellow on this screen is the pelvic lymph nodes. And it starts, there are notes over here to kind of describe the area that it starts. It starts at the top of the anatomy defined on the CT scan. So here's the descending aorta and the IVC. It really starts where they bifurcate. Okay, so these are the common iliac vessels, so vein and artery. The common iliac vessels then bifurcate into the external and internal iliac vessels, which then leads into the presacral lymph nodes right here in the sacral hollow of S2 and S3, and then go down into the pelvis, so external, internal, and then as we come down, you'll see all the way to the obturator, the bottom of the obturator. I like to bring it down kind of into the obturator space and the obturator foramen, kind of a little bit under that. So the parametria, all of this, we'll talk about blocks in just a second. In general, it's going to start at around L5S1. Okay, that's about right there. And then it's going to include the sacral lymph nodes to the S2 interface, S2, S3 interspace, and then you stop your external iliac lymph nodes right above the femoral heads. You do not treat, typically, unless there's some details, you'll typically stop about right there. So we'll talk about the details. So if there is this distal vaginal involvement, you can include, and really you should include the distal vaginal lymph nodes. That's going to look all the way down to the lesser trochanter, going to look down here. They don't have it on this case, but it would go down here and be contoured to the vessels all the way up here. And if you have node positivity, and typically at a minimum, common iliac nodal positivity, consider, and at my center and most academic centers are going to consider treating all the way up to the renal vessels. So right here along the periaortics. And that's called an extended field technique. So you contour all the way up here and all the way down above the lymph node areas. Some practitioners will do an extended field if there is any node positivity. I think that there's been some data in the last year or two where there's more use of extended field than there used to be, and you certainly have some range in your practice to make that decision. So CTV number 3 is the lower common iliac nodes. Superior limit is contoured at essentially a L5 vertebral body down. The PTV, expansion will be done, and we'll talk about that in just a second. But the CTV is placed and should be about 7 millimeters from the L5 junction or the visible common iliac bifurcation. The internal iliac nodes include the obturator lymph nodes and inferiorly the upper third of the obturator fossa and the hypogastric nodes. The external iliac nodes go up to the level of the top of the femoral heads and stop, and the presacral nodes go to the inferior border of S2 and stop, and we'll see the blocks for those in just a second. Include the periac nodes if they're involved. Okay, so we talked about these notes. If the distal third of the vagina is involved, inguinal nodes must be covered with the inferior border as the vaginal introitus. And you, most of the time, will know that based on your physical exam and seeing, does the tumor crawl down the top of the vagina more than halfway down the vagina into that distal half of the vagina. If the posterior vaginal wall is involved, you can consider covering the pararectal lymph nodes as well. And we'll see a block in just a second that would cover that. And if the common iliac nodes are positive, you certainly want to raise the border of your blocks at least 4 centimeters above the known nodes, but consider treating the periaortic nodes if the common iliac nodes are involved. And I give that as a gray zone because there's some variety in the literature. Okay, so when you go from CTV to PTV, we use variable expansions to account for that mobility of the targets. 15 millimeters for CTV1. Some people will do more like 2 to 3 centimeters due to movement. 10 millimeters or a centimeter for CTV2 and 7 millimeters for CTV3 because there's going to be a wider area treated with CTV3 and you align to bones, usually there's much less movement. So I'm going to show you what that looks like. So on CTV1, CTV2, CTV3, you're going to add the suggested margins, okay? So PTV3 is 7 millimeters from CTV3 here. And you can see the green versus the yellow. The uterus is mobile. It moves around the pelvis quite a bit, especially when the bladder fills up and moves. It can even be moved a little bit by the colon, but it moves a lot with the bladder. So you want at least a centimeter and a half, if not 2 centimeters on it, okay? So this red on red gives you an example of how you want to accommodate for that movement there. And then CTV2, that parametry and upper vagina, it's a little bit more stable, but usually a centimeter of movement will get the difference, okay? So all of that is brought together. When you add PTV1, PTV2, and PTV3 together, you create a final target that can be treated that will accommodate for all that movement and treat the areas that are at risk for cancer. Okay, and this is what it looks like. So all in all, that is typically at my center, we use 45 gray and 25 fractions. Some places will use 50, 40 centigrade and 28 fractions. Both of those are perfectly acceptable. But when you look at the difference of across recommendations, it's somewhere between 45 and 50, 40. The lymph nodes and the things that to think about around this are gross disease. So if you have lymph nodes that are positive, you draw the GTV or the target for those. So that would be the GTV lymph nodes. And then typically at my center, we'll add somewhere between 7 millimeters and a centimeter to that. To get those lymph nodes, again, we're treating either with 3D boosts or we're treating with IMRT at my center to get those lymph nodes to a dose closer to 60 gray plus. And we'll do that a bunch of different ways. Sometimes it's sequential, sometimes it's built into the IMRT plan. But I want to show you just, hey, this is how we take care of lymph nodes, and they do go to a higher dose. Okay, so as you get PTV final together, that is the method for doing it. And this is not something that you can really, know how to do and master just by me sharing you. I'm sharing with you a checklist of how to do it, and you need to go work and do it yourself and play with it and then get feedback, which is what this course is for. So the other thing that you're contouring is the organs at risk. So the bladder is the whole bladder. The rectum includes the volume that is inferior to the PTV and superior to the level that it leaves, what we call the rectosigmoid flexure. And I'll show you that. So when the rectum and the sigmoid come together, they flop over. Oh. And when they flop over, we call that the rectosigmoid junction. And this is the area where that happens. So turn off all the targets so this is really clear. So where that happens is right here. This is the brown is the rectum. My bad joke is that all rectal contours should be made in brown and all bladder contours should be made in yellow. Sorry. But you can see it extends up, and then when it flops over, that's the sigmoid. Okay. So that's the sigmoid going up into large bowel right there. And these can be kind of hard to distinguish. You really just got to get into it, and every case will be a little different. But it's where you start to see that bridge or that flop that you start to call it sigmoid.
Dan, we got a great question in the chat of obviously the goal is an empty rectum at time of simulation, but how do you approach, rectums that aren't fully empty at time of simulation, or it's very difficult to remove stool?
That's a great question. You want to balance. So a perfect scan up front doesn't matter if all of your treatments have a different anatomy. So when I work with my patients, I try to find what's reproducibly maximized. And what that means to me is, a little different for every patient. But if you've got a really, really big rectum and they look like they can do an enema, we'll give them an enema. But if they tell me, and they'll poop, and usually it gets better. But if they tell me, doc, I've actually pooped twice today and it's as empty as it's going to get, and it looks still a little bit full, there's a little bit of stool in this rectum. Then I say, okay. And the reason why in cervix cases at least is because when you do your final PTVs, they're actually going to include a lot of the rectum anyway. Because you want to have 2 centimeters, 1.5 to 2, sometimes even 3 centimeters behind the GTV so that you don't miss it. I think if you look at the literature, the most common place that there are misses is right here where the rectum is being treated too tightly. So I always prioritize coverage over OARs because I want to cure my patient. And it doesn't really matter if they have toxicity if they're dead, if that makes sense. And so it's kind of a balance, and it's really uniquely approached to each patient. I hope that answers the question. Sometimes you just can't get that rectum empty. I wish that we could. So the other thing that we have here is the femoral heads, the kidneys, the small bowel. The targets for that you can review here. The small bowel is kind of hard to contour, but I want to show you essentially what we do is called a bowel bag. And that bowel bag kind of encompasses the potential space that small bowel is likely to be in. It definitely helps you to know if there's going to, and these are the loops that matter. If you're putting 60 gray right there, you're going to cause a lot of diarrhea. You need to be aware of where the small bowel loops are. So I think the back of this is the most important part to focus on if you're doing, especially if you're moving towards IMRT in the future. Really keep those lines, don't be sloppy on your bowel bag, especially if you're boosting lymph nodes to over 50 gray. You're gonna reduce toxicity if you're aware of where the bowel is. So, and then the femoral heads, essentially you draw it from the top of the femoral heads all the way down to the lesser trochanter. These are all just basics. There's different ways to do this, but some people will draw all of this all the way down to the lesser trochanter, but femoral head's at a minimum right there where they hit the joint. And then as you move into IMRT, a lot of the IMRT trials were actually used to define the benefit for bone marrow toxicity. So essentially bone marrow is S1 down to the rest of the pelvis in a bone, in the bone in that area. So I'm going to let you guys wrestle with that separately, but drawing each of those is really important. And one thing I'd say, if you're treating the periortics, don't forget the kidneys, because you certainly don't want to move a patient to dialysis because you forgot to draw the kidneys. So, okay,
One other
so
question for you, Dan, that
yes.
came through in the chat. When you're designing your CTV contours, how do you approach when those expansions around vessels get into the bowel bag contour?
So that's a great question. You prioritize coverage over, with the PTV expansion, you prioritize coverage. But this is a good example here. Let's look at CTV3, okay? And then let's look at bowel bag. Great question. So you take it out of the bowel. So there's the bowel bag. Well, I guess they haven't taken it out of the bowel. So when I teach this, you want to see 7 millimeters on the vessel, and even if it erodes the bowel bag. But you'll see what they did here. You can see they kind of came back on the small bowel. They kind of came out of it right there. And I think they're kind of following the edge of it right there. When you're drawing the CTV, you can take it, and in my practice, I take it out of bowel as I'm contouring. So 7 millimeters is essentially everywhere that's not bowel or bone as I go through. So there's a good slide right here, you know, taking it out of muscle, taking it out of bone, taking it out of, other OARs. Okay. So your field selection is something you're probably familiar with, because really it is the same as the 2D area. I'm going to say most of you probably have experience with this. We can use APP fields for thin patients, but in general, we'll usually yield 4-field pelvic box. If you treat with the extended field to cover the periortics, you want to make sure you keep a margin on gross disease. So that margin would be suggested to be 2 centimeters to let your dose build up. I'm not talking about brachytherapy, but I do want to say if you're doing brachytherapy, you can't really boost the parametria very well unless you have a hybrid implant. And so considering a parametrial boost, which we'll show in just a second, is important to do sequentially if you've got parametrial invasion to get that dose to definitive. So the conventional whole pelvic fields are based on anatomy. We talked about the margins of these. So L4, L5, or the L5S1 interface to the bottom of the obturator foramina to cover the proximal 2/3 of the vagina, or the lowest extent of disease with a 3 centimeter margin. The lateral view of this will be 2 centimeters beyond the lateral margins of the true bony pelvis. The anterior blocks will be the margin of the pelvic pubic symphysis, and the posterior blocks is usually through the S2-3 interface, but you may extend if you need to for adequate margin. And occasionally, like I mentioned, if the rectum's involved, you can include the perirectal lymph nodes. When the extended field RT is indicated, you need to contour those kidneys, and you would put the border at right above them or in the middle of the vessels at the T12L1 interspace, or at least 2 centimeters above the highest gross nodes. So this is probably a view that you're familiar with, how to draw blocks in a 2D component. This is interesting. You would think that this is probably a patient that had rectal invasion because the back of the sacrum is involved. If you had a patient who had bladder invasion, you could do it, a little bit further in front of the symphysis. But the point is, draw your target so that you've got 2 centimeters on it. And this is a good view here. This is a view of what all of your lymph node coverage regions will be looking like in that view. And so as you start contouring, it's a good exercise. I want to contour the common iliac, then the external iliac, the internal iliac, the obturators, and different parts of the cervix and vagina drain to different regions. So the back of the vagina will go to the perirectal presacral, the front of the vagina or bladder interface will go more towards the external iliac lymph nodes. Both will go to the internal iliac lymph nodes, and obviously they all feed back up into the commons. As I mentioned, if you cover the inguinals, if they've got disease in the vagina, the inguinals will be draining as well.
Might have you slow down just a little bit for our French interpreter. Thank you so much.
Oh, thank you. At least I'm not translated to Arabic now. Sorry. Let me know when she's ready.
Yeah, you can continue. I think just speaking,
Okay,
giving her a little more gaps is helpful.
no problem. This is what an extended field view would look like up to that T12L1, maybe a little bit higher even if there's lymph nodes above that, and then obviously down to the bottom of the pelvis, blocked as shown. And this is an example you can refer back to of what a parametrial block would look like if you have a wide tumor and or lymph node positive disease. And the joints mentioned for this would be the bottom of the SI joint, to the mid obturator foramen. Inferiorly, laterally is the same as a pelvic field. And then medially, you're blocking the area of the implant that you're going to do with brachytherapy. So this is something that can be done after the external beam component interdigitated during the brachy implant. Okay. So every patient who has intact cervical cancer that's locally advanced should get brachytherapy for cure. Otherwise, all of this was just for palliation. Brachytherapy is the scope of another lecture, but I want to be very clear. The whole point of this was to shrink the tumor down so that you can do curative brachytherapy. There's a great paper that I cite here that talks about the workflow for brachytherapy. And I think it's important to think of where you're going at the beginning of your case so that you can see this workflow in your mind of all the steps that need to happen to execute good brachytherapy. And I'm not teaching this right now, but I want to show this as a good resource. And certainly the citations of the NCCN would be the gold standard place to look, but this is a good paper. So that was a lot. You cannot learn all that or feel like you have mastery of it by hearing it. You have to do it. It's like any other craft. And so you should have received instructions via email of an opportunity that you have for contouring practice. So as clinicians, you will contour a sample intact cervical case, modeling the one that we just did in ProKnow. You'll get instructions on how to do that. And the physicists and dosimetrists will have the opportunity to plan a case, draw the blocks, and upload that plan to ProKnow. So this is really, really neat, in my opinion. ProKnow is a great platform, and in previous courses, this has really been helpful for people. So what I want you to do, take all those things I told you to look up, take this, it's really a checklist of PowerPoint, and then move into practicing it across your career. So the take-home points from this are really based on the phrase, if you do not have a system, you will systematically fail. And that is what I have found to be true. When I don't have a system, I systematically fail. So creating a system for yourself, the checklist from the simulation slide that I gave you, thoughts and processes from that, the contouring steps from the e-contouring site that we demonstrated and what you'll do in ProKnow. And then as you move into planning, which again is really beyond the scope of this talk, there are constraints, which was the point of all of this contouring, so that you can spare the normal structures as much as you can while still treating the cancer as much as you should. And the NCCN has an excellent resource to describe, in our setting at a minimum, the goals that IMRT would at least have, but give you an idea of what the highest standard could be. I understand that this is not always what you can achieve at every center, and certainly that's reasonable, but I want to elevate your standard and show you where the opportunities are. So again, the references that I cited was the NCCN. The NCCN is summarized in the ESTIS tables. You've got all of those websites, and then those resources you can find them are loaded with primary literature, deeper dive topics. And I think my goal for this day is to understand for you how to fish and show you the resources and give you an explanation of the steps, but show you what to go back to for your checklist.